Welcome students to the topic directly acting muscle relaxants. So the name of our directly acting muscle relaxant is Dantrolene. So Dantrolene is pharmacologically and chemically different from the neuromuscular blockers, but the action is somewhat similar to the centrally acting muscle relaxants. So Dantrolene does not interfere with the neuromuscular transmission. What it does is it uncouples contraction from depolarization of the muscle membrane. If you remember the video of excitation contraction coupling, so the neuromuscular junction where the acetylcholine is stored in the vesicles of the axonal terminal is released into the synapse. So in the synapse, it goes and binds to the nicotinic receptor on the skeletal muscle, opening up of the nicotinic receptor uh, sodium channel. So increase of sodium influx will be there, which will produce depolarization and initiation of action potential. So that depolarization and initiation of action potential cause the excitation of the muscle, which produces release of calcium from the sarcoplasmic reticulum, which produce contraction. Remember. So, this depolarization triggered release of calcium from the sarcoplasmic reticulum is blocked or reduced with dantrolene. So, dantrolene mainly acts on the ryanodine receptors, that is RYR1 and ryanodine receptors, which is embedded in the sarcoplasmic reticulum of the skeletal muscle. Okay, and it prevents the calcium released from the sarcoplasmic reticulum. So this calcium is required for the excitation contraction coupling because dantrolene is inhibiting the ryanodine receptors. It interferes with the excitation contraction coupling. So it mainly affects the fast contracting twitch muscles more than the slow contracting anti-gravity muscle. And dantrolene does not affect the smooth muscles or the cardiac muscle because dantrolene mainly acts on the RYR1 receptor, which is present only in the skeletal muscle. In the smooth muscle and cardiac muscle is RYR2 receptors. Coming to the pharmacokinetics of dantrolene, dantrolene is absorbed orally from the GIT. It can penetrate the brain and produce some amount of sedation, but has no selective effect on polysynaptic reflexes responsible for spasticity. It is metabolized in the liver and excreted by the kidney with a T-half of 8 to 12 hours. Adverse effects of dantrolene: it can produce muscle weakness, sedation, malaise, diarrhea, and liver dysfunction. So dantrolene can be used orally as well as intravenously to reduce the spasticity in case of upper motor neuron lesions or disorders, paraplegia, hemiplegia, cerebral palsy, as well as multiple sclerosis. However, it can reduce the voluntary power. Dantrolene is a drug of choice for malignant hyperthermia. So what is malignant hyperthermia? It's a pharmacogenetic disease where there is abnormal ryanodine receptors. So the symptoms of malignant hyperthermia will be increased rigidity, contraction, increased heat production, accelerated muscle metabolism, metabolic acidosis, and tachycardia. It is usually triggered by any of the halogenated hydrocarbon anesthetics like halothane and isoflurane and even succinylcholine. So it's an autosomal dominant trait seen with abnormal ryanodine receptors. So because of that, there is persistent release of calcium from the sarcoplasmic reticulum in genetically susceptible individuals with abnormal ryanodine receptors. So there is uncontrolled release of calcium from the sarcoplasmic reticulum of the skeletal muscle, which is producing all the symptoms. So the drug of choice is dantrolene, given IV 1 milligram per kg. The patient can be given rapid cooling to reduce the body temperature, inhalation of 100% oxygen, and control of acidosis has to be done. With that, we come to the end of directly acting muscle relaxant, which is dantrolene. Thank you.